Good afternoon, everybody. In fact, thanks to Dr. Shah for bringing me on the podium. Last year, I was talking online. In fact, when I think about all these things, I think when we were doing our DM under Professor Mehta, we never had any problem about this calcium nodules, etc. It was only one thing, rota, no imaging, nothing. But things are very simpler, but day by day it becomes complicated. Now, the tough job is OCT versus IVUS, when to choose what. Now, since morning we have been listening about OCT and IVUS, everything is good, but let us try to see what happens. This is not a debate, not with one coming with a dynamite, another with a bomb. So it is just that we should have an insight, and I'll give my take about what I feel, where OCT should be placed and where IVUS should be placed. For example, if I show you this picture, can you identify a crocodile and an alligator? Very difficult. You must have seen multiple times crocodiles, multiple alligators. The simplest answer, the crocodile is next to the alligator. That's a very easy to say. So that is why this is where the two spectrum comes, whether OCT or IVUS, both are complementary, but I'll give about my take. Now, when to use IVUS and when to use OCT. Commonly, when you used to see the angio, the first thing that you said, dude, I just see a hole, nothing else more than that, some plaque. But believe me, after this imaging came, there is more to see and evaluate. And people go on evaluating so much, and the table on the patient is on the table, and then the next cardiologist knocking at you that you have to clear the table because I have got two more patients. That's the whole thing. Now, my take about all these things will be on these subset: out-osteal lesions, LMCA, bifurcation, calcific, ACS, tackling ISR, BRS, CTO, renal failure detecting. All these subsets have been dealt with. I'll quickly go with some examples. First, out-osteal lesions. See the typical left main osteal lesion. Very difficult to know with OCT. The best thing is to go ahead, take an IVUS, do the procedure, and you see the pre and the post. There are specified criteria where you know that you have done a good job. So definitely IVUS is the answer. Now here, supposing in this case, you might feel that the osteal, all osteal are to evaluate it properly. For example, this case, the MLA is 4.11. So this needs that you have to work on it, use a cutting balloon, and then go ahead. Cleaning blood from the out-osteal junction is really difficult and it's problematic. So definitely IVUS is the choice when you're dealing with LMCA osteal lesions. Next, we come a little bit further to the LMCA lesions. I find this quotation very important. We are among interventional cardiologists here, but it's important to realize there is a scrutiny in the left main space because the results of the surgeons are good. The surgeons are much better than us in left main. We have to accept that. Whatever may be the reason, whatever amount of debate we do, and if it is our relative, possibly we would have sent it to the surgeon. So just don't consider the LMC as a tubular structure. As it is said, that definitely intravascular imaging is beneficial in LMC lesions. But when do you do it? All LMC interventions. This is the take-home message that should go. If you're dealing with LMC lesions and you have to compete with your surgeons, you have to use it in all LMC lesions. There may be borderline LMCA and osteal LMCA, shaft and distal. For example, whether to stent or not, this is a very common diagram from the JAC, which shows that if it is in 4.5 to 6, you go for FFR. If it is beyond 6, just leave it alone. If it is less than 5, try to do something for it. Now, these are the recent criteria which states that we do not stick to the numbers of 5, 6, 7, 8. We now have to go to the numbers of 7, 9, 12. This is the minimum criteria that we have. But of course, Indian population is a little bit lesser in size than the Western population. So we have to follow it. And the values are only validated by IVUS. It is not validated by OCT. So the take-home message is IVUS is for left main. So these are the figures that we should attempt. What we should aim for, as I told, larger the better. But at the same time, if I show this case, this is a shaft left main with a LED, where I went ahead with this thing that is IVUS, and I saw that there was a very fibrotic plaque and the area was significantly occluded. So the next thing to be done was to just go ahead and go for a single stent strategy after doing a cutting balloon. And post cutting balloon, you can see how the cuts have come. You can see the red arrows which are showing the cuts. And after the cutting balloon, you can see it has expanded to 6.55, but there's still more to do. That is, you go with take a run from the circ to the LMCA so that you're sure that you're not obstructing the osteal, and then go ahead with from the LMCA to LAD, and you have acquired a 10.7, which is more than sufficient for your LMCA. So in LMC lesions, you have to be very careful, because just to doing a stent, putting a stent does not finish the job. There is something more to be done than that. Now, it is seen that in LMC lesions, almost 74% of the patients we have to change our strategy. We may think that we have done a good job, but possibly not, so we need to change. Now, if you ask me, where do I use LMCA, OCT and IVUS? If it is an ostium, mandatorily you have to use an IVUS. If it is the body or the bifurcation, you can use either of them, because sometimes it is very difficult to imagine, because it's very peculiar. All LMCs are not same, so you have to be very careful that where to use which modality. But IVUS would be my choice of this thing, imaging in LMCs. Now, so IVUS course over OCT in left main, mainly ostial, and usually if the vessel diameter is more than 5, because many left mains that we deal are more than 5, and OCT will not cover in the spectrum, and you'll see that is not possible. Now, very little data with OCT about LMCA lesions, so try to stick to IVUS. That's a clear-cut message that should go. Next, come to bifurcation lesions. We have two questions to be answered. Will my side branch be compromised, or should we go for a single stent or a double stent strategy? There are all guidelines which some people say it is single stent, some people say double stent, with the complex, the lesions. So we know there are certain eyebrow signs, which is LMC LAD, which gives us an idea from the angio itself or on the IVUS that no, we need to go for, need to expect that this might occlude. Now, baseline, you have to do an IVUS run and have to see. And then if there is an IVUS sign is present, and the eye sign is present, eyebrow sign, possibly occluding. So be prepared to keep a wire there and try to see what is to be done best. OCT has good predictors in side branch occlusion. There are two things: the cranial angle, which is less than 50, or the BPCT, that is branch point to carinae tip angle, carinae tip length should be less than 1.7. I'll show you two examples. Bifurcation lesion, how I decide one stent is possible. Take this case, a 48 years male, recent ACS. I calculated the CT angle and the BPCT length. BPCT length is 2.7 millimeter. The cranial angle is more than 70 degrees. Single stent only. You'll never crush your side branch. Very simple, single stent, keep the procedure simple, and there is the lesions. Why the side branch is flowing well, you don't have to be worried. So OCT helps by specific criteria about how to do a bifurcation. The next case, which I'll show, where to use a two-stent strategy. Now, you see this case. It has almost a Medina 111, the LAD diagonal lesion. Here also, when I took the runs, I saw that the BPCT length is quite small. It is 1.5, and the cranial angle is just somewhere around 45 degrees. So outright two stent. No, nothing to worry. Go for two stents, where you'll fall in trouble if you go for one stent. So this is the steps that was a DK crush was done, and this was the final results, the pre and the post, and the post PCI LAD run of the bifurcation, which shows the lumen to the circumflex is very well opened up, nothing to be worried, and you can leave the patient very safely because the stents are well opposed. Now this is a post PCI diagonal to LAD, where you can see everything is well opposed, and the patient has got a good carina, the results are good. Both are useful in bifurcation. What you have in your lab, you have an IVUS and OCT. I have both, so it is my prerogative, and seeing the patient's pocket, I use what I have to do. Now let us come to calcific lesions. Both are good, but definitely for OCT is better. We have demystified the calcium scoring, and we have good scores where, for example, as Dr. Chadda was showing about a calcium nodule, you can see something in the right coronary artery. You can see something, structure. Is it a thrombus or is it a calcium? This can only be known when you do a pre-imaging OCT, where you can see the calcium nodule very much present. There is a 360 degrees calcium, there is a calcium nodule, there is calcium. So naturally, you have to debulk this lesion, and the way to do it best is what I thought based on the calcium scoring. The calcium scoring had 2 points of the arc, 1 point of the length, and 1 point of the thickness. So naturally go for higher modality of debulking, and the best what I could use was IVL followed by a NC balloon, and that did the trick. Went with an IVL 3.5 into 12, 6 atmosphere, 10 cycles, 100 pulses given, and this is the imaging where you can see the post-IVL cracks. You can see the cracks very well, and this means that you have done a job well, and you straightforward go ahead with the NC balloon and then deploy the stent after the NC balloon. The results will be definitely good. So these are the final OCT pictures, but you can see the lumen area has gone up to 9.21 even in the calcium nodule, but don't be too aggressive because you may rupture the artery. So this is how OCT helps us in calcium nodule, and possibly that is the tool that is to be used, because in calcium nodule in IVUS you get lot of reverberations and you are not able to see what is beyond. That is the final results that you can see, the small calcium nodule. This is in fact a member of the parliament who presented with ACS, and this was the problem with him, and I couldn't know what to do. I thought it's a thrombus, but it was a calcium nodule. Now, a very problematic thing is when we do not prepare the bed and we just go ahead and do a stenting. This is what happens. Now, if you see this thing, the stent has been given, and this was done by one of my registrars. In fact, he did it. He thought it's a cakewalk, and you see what has happened over here at the red arrow. Still, the stent is not opened up. So here, this OCT gives us a lot of idea, because OCT penetrates the calcium best compared to the calcium on the IVUS. So whenever you see calcium, think of the Titanic, because OCT helps in managing calcific lesions in a calculated manner. The Titanic sank because it didn't know where the iceberg was. That was the whole problem. So now there is quantifying calcium can be easily done on OCT, and based on that, on these three criteria, we know what is the protocol to be followed. For example, this one, balloon uncrossable lesion, looks calcific. So the best thing to do is, you can see the time track calcium over here. So you are sure that is a 3-cysteid is calcium, and it's a balloon uncrossable lesion. So the best thing is to go for a rotational atherectomy or an orbital. We didn't have orbital that time. This was a case done in 2020. So this was what we did. We just went ahead with the rotational atherectomy, and then this was a post-rota, this thing calcium debulking, which you can see, but it still needs work to be done. So you had to work on an NC balloon, and finally post-NC you can see it has expanded well because the shaving has been done, and based on this we could put in our stent, and this is a result of post-stenting, where we can see that the stent has expanded. The area that was totally occluded or very constricted has expanded well. So these are such cases which can be easily seen on OCT, and the results are good when you do it. Deciding when to use IVL, very clear. You do a calcium scoring either by the IVUS, this is known to all of you. But then came the generation when I started working with the 40 megahertz. For 6 years I worked on 40 megahertz. It was like the standard TVs. But then came the high definition TVs that were the 60 megahertz. And believe me, the 60 megahertz IVUS is almost similar to OCT, but I'll show you some cases where I've done OCT and IVUS in all these cases. For example, calcific lesions. If you see the first image that is of OCT, you can see almost a big chunk of calcium. Same thing with the 60 megahertz IVUS, you can see there is a big chunk of calcium and nothing seen between. So these OCT and HD IVUS can be compared and can be usable in such cases. And you see after the IVL has been done, you can see the cracks over here, and also you can see the cracks on the IVUS. Only thing is that IVUS is easy to use, OCT is easy to use, means easy to interpret but difficult to use, but that is the vice versa for IVUS. Next, the stent was given, it was compared, a larger lumen seen in the IVUS, a smaller lumen seen in the OCT, but the stent is well expanded and is well opposed. Next, the problem with calcium on IVUS is that there are reverberations. The scoring systems are not very well documented. The OCT would be my choice if it is for calcific lesions. Then let's just come to ACS lesions. ACS lesions, we know that we have to do an OCT because we want to know whether it's a plaque erosion or a plaque rupture. If it's a plaque rupture, it's a stent. If it's erosion, it's all your pharmacotherapy. Now, imaging modalities have improved so far as IVUS or OCT is considered in acute coronary syndromes. This is a plaque rupture where I have done both the IVUS and the OCT, and you can see this is a classical case of the plaque rupture where you see, and similarly what is seen in an IVUS. So both are comparable. If you don't want to use more of contrast, do a good imaging with IVUS and you can get it. So stent this lesion because it is a rupture. Similarly, the erosion, you can see that you can clearly see the erosion on the OCT and you can see on the IVUS. It's a little bit difficult to interpret an erosion on IVUS, but if you're used to interpreting images, you can see how the IVUS looks like. So I do a lot of cases where I do both modalities just to check my knowledge, whether my knowledge of IVUS is correct or whether, because OCT confirms a lot of things which IVUS doesn't, and you keep learning in that way. So no stent over here, just leave the patient out. Now, red or white thrombus, erosion or rupture, all you can know by OCT only, no IVUS. Next, tackling ISR, definitely for ISR, the best way to do is to go for an OCT. So, for example, this case was a case of 2011, which was done, and here we did an OCT to know what is going on. There was an ISR of the LAD in 2020. So, after 9 years, this patient comes, and this is what I see in the ISR of the different segments after a little bit of predilatation. What do I see? I see a long segment involving a 90% of the stent length, beyond the stent and proximal to the stent. It was an undersized stent that I had put in 2011 when we didn't have imaging. Significant luminal narrowing. It is a homogeneous one and extensive neo-intimal proliferation. So here normally what I do, I debulk with a cutting balloon, use a NC balloon, go for a larger size stent with a different compound, post-dilate at high pressures, and finally check with an OCT. This was done, and finally this was the result. And if you see the pre and the post ISR intervention with a 338 stent, and if I show you the images of the OCT post this thing ISR stenting, it looks pristine. The diagonal is well preserved, the LAD is well preserved, and there is almost 90% apposition well expanded, and the apposition index shows white line all across. Strut coverage, new atherosclerosis, stent failure, always go for OCT. Now, let's come to imaging BRS. We have to agree that for imaging BRS, OCT is the choice of imaging modality. And this is what happened. This patient underwent an BRS, and you can see whether the images, there is some amount of malapposition. This can be further dilated, but I have got cases where the BRS fractures. You go to very high pressures, but finally you get good results and you can leave it at such. So for imaging, you get a better visualization of the device and ideal follow-up for follow-up in these cases. So OCT is a choice of imaging modality. Let's come to CTO. CTO requires a lot of flushing during OCT and may propagate dissection. So IVUS is the point of interest. In fact, I have not brought any CT. Here you take the CTO catheter to the side branch, and from the CTO you can know where is the proximal cap and try to assess it if you are in the true lumen, and then optimize your post-treatment this thing that is results. But here you might have to take a 8-inch guiding if you want to do the procedure along with the imaging catheter and along with all your devices. Last, PCI and renal failure. We know that low and no contrast PCI IVUS helps. It is a hyperreality. Definitely, if the patient is an advanced renal failure, use saline flush for protection. For example, this is a very simple case for a patient of CKD with creatinine of 7, where the 2 marker wires are there. You just do an IVUS, put your stent, and just then finish it off with just 3.5 plus 3.5 cc contrast. One for the imaging, one for the last shot. This is all that is done. So pre and post stenting angiograms can be easily done, and people are doing a lot of work on this, on post this thing that is no contrast procedures. But I believe that is a misnomer. There should be minimal contrast. Then contrast load may exacerbate renal function, so always use IVUS in CKD. Lastly, detecting complications. For example, this is a case of proximal LAD lesion where there is a tight lesion on OCT, and for this case, extensive dissection occurred when balloon was used in the LAD. Now the problem was, for this extensive dissection, I had to put another stent from the LAD till the LMCA, and after that you can see the results are very good and we have achieved whatever are the required diameters, 100%. Now, supposing you have a dissected LMCA, sometimes you might have like this. The coronary angiogram was done in another center, and they did this thing angioplasty of the proximal LAD. And what they did was the PTC of the posterior done at 3.5 into 29 DAs was put. And what happened later on was the artery got closed. They didn't have any imaging method over there in that center. And moreover, the patient started having chest pain, was immediately shifted to our center. And this is what we saw. There's the last dissection, patient reaches our hospital with ongoing angina and hemodynamics, but were luckily stable. I just told him, don't take out the sheath, just send the patient to the sheath inside. And this is what we saw. And you can see how the dissection has taken place in the left main. And so there is no other way out but to take another stent, cross into the true lumen, put the stent and come out. So this is what I did. A 5 millimeter into 22 DAs was put, and this was the final result, what we got after putting a second stent. And this is the result where you see the left main is well protected. The patient became asymptomatic and finally did well. Detecting complication dissections, definitely OCT is better, but be careful, because if you have a 60 megahertz IVUS, you can use it if you don't want to use contrast or you don't want to give forcible injections. So definitely you have to take a choice between the two. Now, malapposition and under expansion, angiography cannot help. Even like, for example, malapposition is when how many stress are beyond this 200 microns, and under expanded stent is a stent which does not expand in the heart eccentric lesion. Very simple. This is malapposition and this is under expansion. So you have to differentiate between these two. What is malapposition, what is under expansion, and you have to go, and OCT helps in that. I'll show you an example. This is an acute anterior MI, window period 15 minutes. The patient was taken on the lab for a primary angioplasty, thrombosuction done, stented, post-dilated, port done, and finally you see what you see over here. It is still under expanded. Malapposed, under expanded. So here what has to be done, you go for a higher size balloon and go with a 4.5 balloon, you start expanding it and you see it is well apposed now. This is the final OCT. So if you have to detect very clearly about malapposition and under expansion, get an OCT done, and that really helps. So this apposed and well expanded. So now both these images are like the third umpire. If you cannot detect anything, call for the third umpire and they will give you the detection. They will tell you what is to be done. Is he out or is not out? And I finish with it that don't be deviated by these colorful images, because even these black and white images are equally good. But you have to choose. This is not a tug of war. You have to choose which modality to place where. So here I finish with a very simple story that two buffaloes were waiting. They were waiting something seeing on the river. First person told CH is enough. The other person, no, IVUS or OCT is required. The first buffalo was very confident and he told that, let me jump in. It's nothing but a log of wood. So he jumps in. It's nothing, just a log of wood. Nothing, still nothing, log of wood. Finally, there was an alligator who gobbled him. And then the next buffalo says, no, OCT or IVUS is required. So this story is that don't underestimate any lesion. Whatever imaging modality you have, use it so that you get the best thing. As it is said, to summarize, that you use OCT in all these conditions to study the morphology, length, diameter, polarization, dissection, apposition, expansion, and keep your IVUS for CTO, LMCA, Australasian, advanced CKD. So this is my take home, that this is where you have to place your devices. What? So I finish with it that it were lucky that it is now a class 1A indication as per the European guidelines, and any form of imaging, whether an IVUS and OCT, can be used to see that you do a perfect job. So two cats, black and white, it doesn't matter. The color of the cat doesn't matter as long as it catches the mice. Thank you very much for the patience.
Thank you so much, sir. Thank you.
Thank you so much for Dr. excellent talk on IVUS and OCT. Any questions?
Hello. So I just wanted to ask one question. In case of medial dissection or flaps, if you are using OCT, what special care you ask your registrar to take while injecting the saline or the contrast?
See, normally, if you are very clear of a dissection on the angio, you need not go for an OCT, number one. Number two, if the dissection is very extensive and you see that you're not able to differentiate between the true lumen or the false lumen, something of that sort, you have to be very careful injecting. I usually use a hand injection. I don't go by an injector. Because sometimes we just need the information that what is the extent of the dissection, from where to where I have to land, and what will be the size.
If the wire is in, then better to stand first and then image.
Yes, put in wire, and I always what I do first take a run of an IVUS. If I'm very comfortable my wire in the true lumen, then I see what is taken OCT also. I use them interchangeably.
Okay, thank you.
Sir, we have IVUS criteria which were being used like 5, 6, 7, 8.
Yes.
So 7 was for POC.
Yes.
Now with the recent advancement,
You go much higher.
yes. So
But POC is not important these days.
it's not.
No, it's not.
So there is no need to go ahead with the both.
Don't go calculate. Just see the main, this thing, artery.
Figure of 8 is enough.
Figure of 8 is enough. Try to achieve more in LMCA, up to 11, 10, the more the better. So long you don't cause any complication.
Sir, you have shown the last case where the left main dissection was transferred to your center.
Yes.
So at that time, by injecting the dye to get the OCT image before stenting, that is any
Actually,
special-
what happened, first when I crossed the wire, I was not sure whether it was in the dissection or not. I took a risk of doing an OCT to know whether I was, till what is the extent of the dissection. That is why I did an OCT.
Regarding the newer AI-enabled technology, will make a difference with IVUS and OCT interpretation?
Yes, no. People are more into AI, but trust your eyes more than the AI. That is what I'll say.
Sir, these osteal lesions with OCT, with the telescope catheters and all those things, I think you can still get away with, if you don't have an IVUS, I think you can still get away with an OCT, isn't it?
Yes, it is correct. But what you do that when you push your telescope catheter inside, then you start having problems. Because in the IVUS, you can keep your guiding outside and you can take it. Because not necessarily that the ostium has to be round. It may be a conical sapid or something, various shapes of this thing, ostium is there. So I prefer to use this thing that is IVUS in osteal lesions. That is my this thing device of choice.
About the saline OCTs, I think that also are now quite possible, mainly in LEDs and all, maybe RCS may be difficult.
LEDs, no.
Yeah.
RCS means I don't use saline. In fact, people go very good images, but I don't know. My technicians, I don't get so good images.
Regarding the IVUS catheter of Philips, means Volcano and this one Boston, deep difference is there. So in CTO specific things.
I have no experience with the Philips catheter. Both my devices are of Boston.
Thank you very much, Dr. P.K. Sahoo.